Welcome, everybody. This is Deanna Jang, and I'm welcoming you to the Asian and Pacific Islander American Health Forum hosted webinar on how will healthcare reform impact Asian American, Native Hawaiian, and Pacific Islander communities. This webinar today will provide a general overview of how healthcare reform will impact the Asian American and Native Hawaiian and Pacific Islander communities. We only have 1 hour for the webinar today, so unfortunately, we won't be able to cover everything in the over 2,000-page new healthcare reform law, including some specific sections. For example, the Native Hawaiian Healthcare Act got reauthorized for 10 years. But we will provide everyone with a basic overview of what's in the bill. And at the end of the webinar, we hope to get your feedback on ideas for future webinars where we might be able to go more deeply into some of the specific provisions included in this 2,000-page bill. So just a little bit about the Health Forum. The Asian Pacific Islander American Health Forum, our mission statement is to influence policy, mobilize communities, and strengthen programs and organizations to improve the health of Asian Americans, Native Hawaiians, and Pacific Islanders. And next year we're going to be celebrating our 25th anniversary, so we look forward to having you all be on our list so we can let you know about our celebrations for that. But for today's webinar, we have 4 speakers, and I will act as the moderator. First, we will hear from Ann Widger, who's the Deputy Associate Director from the White House Office of Public Engagement. Next, we will have Alice Dong, who's a Senior Policy Analyst with the Asian and Pacific Islander American Health Forum, followed by Rita Pinatas, who is the Minority Health Initiatives Director at Families USA. And then finally, we will hear from Sonal Ambagalkar, who's the Health Policy Attorney at the National Immigration Law Center. We hope that today's speakers will really provide you with a great overview of the bill, as well as focusing on some of the issues of health disparities and immigrant access. Just to give you an overview of the webinar, we will want to look first at how the Asian American and Native Hawaiian and Pacific Islander communities currently fare in terms of health and some of the factors influencing their health. Then we want to break down the issue of healthcare reform under the themes of access, affordability, and quality. Then we will consider some efforts that our community advocates can make at the state level as states begin to implement healthcare reforms. And finally, we'll have a question and answer session. For the question and answer session, please use the dialog box on the right-hand side of the screen to type in your questions at any point in the webinar. We will be taking questions at the end of all the presentations. So please, as you're listening to the presentations, remember to type your questions into the chat box, and I will be, into the question box, not the chat box. Use the question box, and we will try to get to as many of those questions as possible at the end of the webinar. So to start with, I want to turn it over to Ann Widger from the White House Office of Public Engagement so that she can discuss the resources that the White House has available to conduct outreach to explain the law to our communities and how it can provide other resources for us. Thank you, Ann.
Great, and thank you. And first, I guess I want to start by thanking all of your organizations represented here on the phone and all the participants today, because I know how hard you all worked to help us pass this legislation, and so I just want to thank you for all the work that you have done, and sort of give you a pre-thank you, because I know that you will be our boots on the ground in making sure we get good information out to all communities across the country, and there certainly is a big need now that we've passed this to make sure we educate folks in terms of what's available to them, what's actually in this bill, sort of dispel some of those myths. And as you can imagine, here at the White House, we are just beginning this process of figuring out sort of how we're moving forward with outreach around health reform implementation. Obviously, there are quite a few agencies that come into play, Department of Health and Human Services being obviously the department that's going to be carrying the bulk of this information and work, but then the IRS, Department of Labor, and so the White House here is kind of bringing all of these different agencies together, making sure we're all moving forward consistently, going through the regulatory process on certain regulations that are being written to get the pieces in place that need to be in place, because there are quite a few immediate benefits in this bill. And I know all of your organizations on the phone get regular updates from me with timelines, fact sheets, and such, and I know that you all are passing those on to your grassroots folks. But I would also welcome everybody to visit a couple of websites where this information is being held and will be updated on a regular basis. And those two websites are the White House website, which is whitehouse.gov. And you just kind of click on the healthcare issue there, and it'll have all of our newest up-to-date fact sheets. And the other one is healthreform.gov, which is the sort of more of the HHS portal for health reform information. So I would welcome you all to visit those websites and visit them all on a regular basis. Also, the White House blog, we tend to post real up-to-date things there as well. For instance, this past Monday, we had a copy of a postcard that was sent out to many small businesses around the country, hundreds of thousands of small businesses across the country who may qualify for the small business tax credit for providing their employees with health insurance in the short term before the exchanges and the rest of the health reform pieces get put into place. So that's one of our immediate benefits, and that blog has up-to-date information in terms of education and outreach activities that are going on. I know you have a lot of wonderful experts on the phone, so I won't go through the ins and outs of the legislation, but I think you all, just hearing the introduction are focused on the right pieces, which is access, affordability, and quality. I mean, those were the pieces all along. There are many things that are happening right away. There are some things that we're even trying to speed up. For example, the stipulation that insurers allow children up to the age of 26 to stay on their parents' insurance goes into effect for plans starting 6 months after enactment. So it's like September 23rd, 2010. But you probably have seen some press recently that we've been working both here at the White House and through the Department of Health and Human Services with some insurers to actually put this in place earlier, because we have students that are graduating from school right now who shouldn't have to have that gap in coverage moving forward. So we're trying to look at these different issues like that one and put them into place in the most meaningful way. And we look forward to working with all of you moving forward to get your guidance on what will work best for your community and on what type of information you need to provide out to your community. I guess I would just end by saying there are some great things in this legislation to work down the road to fight health disparities among Asian Americans and Pacific Islanders by investing in data collection and research about disparities and expanding initiatives to diversify our workforce and strengthen cultural competency and training among healthcare providers. And then there's, there was a piece in there too that I'd like to highlight for folks that actually elevates the National Institute on Minority Health. It was a center, and now it's an institute, so it's sort of enhanced its focus and its stature within the Department of Health and Human Services. So that, I hope, shows folks sort of our investment in making sure minority health and disparities issues are addressed. So as I said, I know you have plenty of experts on the phones that will go in and out of all the different pieces of the legislation with you, and I'm sure this is the first of many of these web chats, but I just want to thank you for everything that you've done and everything that you all plan to do moving forward.
Yes, Anne, thank you so much, and I really want to thank the Office of Public Engagement for all the work they've done to really reach out to all the different communities. And I know you're not going to be staying with us for the webinar, so I just wanted to run a couple of questions by you that people sent in. First of all, how do you get on the White House Office of Public Engagement list so that people can be directly emailed these fact sheets when they come out?
Sure. The best thing to do is to actually email our public email address, and that email address is public, P-U-B-L-I-C, at who.eop.gov, and then we'll make sure folks are on the appropriate list, whether it's my list around healthcare, whether it's Calp and Modi's list on the Asian American Pacific Islander side, or both. Folks can certainly email that public email address, and then it'll get passed on to the appropriate folks. And again, that's public at who.eop.gov.
Okay. And just to let people know, at the end of the call, we'll be talking about the Health Forum is going to be setting up a healthcare reform resource page, so we hope to link to these resources as well. And then, Anne, I think another question people ask is people are very interested in the coverage for dependent children up to age 6. And will there be some specific, or is there some specific information available about that? Yeah,
we'll make sure, and I'll make sure either myself or Calpen sends our sort of young adults fact sheet on to you guys so you don't have that, in case you don't have that. So that information is on there, and there will be sort of, some of these regulations that are being put in place. There are some detailed information and regulations that we're going through in terms of how the healthcare providers are actually going to set up their coverage based on the new law. There are restrictions in terms of what we are and aren't allowed to talk about during the regulation process. But since it's one of the absolute immediate benefits and one of the benefits that we're trying to speed up as much as possible, I think you'll be seeing more from us on that moving forward. I mean, the basic information is that the law says that plan year starting within 6 months after enactment, so that would be September 23rd, 2010, have this requirement to cover children up to age 26. And they'll be further fleshing out through the regulatory process of what that means. And when that gets released, we'll make sure you all get it.
Okay. Thanks very much, Anne.
No problem. Thank you.
Okay. Thank you. And as Anne indicated, even though, in addition to the fact that the law itself is over 2,000 pages, there's going to be many more thousands of pages because you'll notice as the speakers speak that the devil is in the details, and there's many more pages of details to come through the regulatory process, as she indicated. So let's go ahead and get into our panelists. Alice Dong will begin with a presentation on the state of Asian American and Native Hawaiian and Pacific Islander health. Just to give you a little bit of background about Alice, she's our senior policy analyst at the Health Forum. And in addition to her current work on health policies that would advance the health of Asian American and Native Hawaiian and Pacific Islander communities, she previously served as a health law policy attorney for the Asian American Justice Center and has worked on the passage of the Americans with Disabilities Amendments Act. She holds a law degree from Georgetown University Law Center, where she published work on women's reproductive rights. So take it away, Alice.
Thanks, Deanna. So first, next slide, please. So first, let me provide a quick overview of the state of Asian American, Native Hawaiian, Pacific Islander health to sort of draw attention to why we need health care reform. As we all know, there is this model minority myth that our communities suffer less than others and actually are in pretty good health, but we know that when we look at the data, when we look at our subpopulations, there are huge and serious issues around conditions like hepatitis B, breast cancer mortality, cervical, stomach, and liver cancer, mental health illness, and certainly the rate of increase in childhood obesity. Next slide, please. So compounding these health issues, there are also other social factors that are more than just the conditions and diseases themselves. And these other factors contribute to poor or suboptimal health. Just a few examples are poverty, rate of uninsured, limited English proficiency, and immigration policies. Next slide, please. So when looking at some of the data that that is available, and looking at poverty, for example, in the white non-Hispanic population, the rate of poverty ranged from about 8.2% in 2004 to 8.3% in 2006. Now, if you look at the light blue bars, certain populations have up to 24% poverty levels in our communities. And looking at the next slide on health coverage, we see that within the general population, there's about a 61% level of employer-sponsored health coverage, whereas within our communities, we see that it's as low as 46%. Moving on to limited English proficiency, it's about 8.7% amongst the total U.S. population and about over 50% in portions of our population. So that means that there's difficulty understanding prescription labels, there's difficulty understanding doctor's instructions, as well as communicating the health issue to the doctor in the first place. So given that quick overview, and also we've also seen that there is data looking at the amount of preventative care counseling that Asian Americans receive, and this is for the population of Asian Americans that actually went and saw doctors, that the level of counseling they receive and prevention is lower than the general population, and you can see that reflected in the yellow bars on the slide. So now that we've taken a look at an overview of some of the health disparities that affect our populations and all the other social factors that just make those situations more difficult to deal with, I want to present an overview of the healthcare reform legislation to sort of demonstrate some of the improvements that our communities are going to see as a result of this new legislation. Now, as Deanna mentioned, there's over 2,400 pages of healthcare reform legislation, so we can't include all the reforms on this call. And we'll talk later in the webinar about suggestions for additional informational sessions on more focused and specific issues. So we'll definitely be looking forward to your feedback at the end. So in looking at what is in healthcare reform, first, just as a general background, healthcare reform refers to a combination of two bills, both of which were signed into law by the President just last month. And this reform aims to really provide more affordable options to the low and moderate income, and also to improve the quality of care provided. So quality of care meaning not just improving the number of people that have health insurance, but also ensuring, for example, that there is cultural and linguistic access, that there is an emphasis on data collection in our communities, and many other aspects to care that go beyond just an increase in health insurance. So first, we're going to look at what this legislation does in terms of improving access for our community. So what does access mean? It means both the availability of benefits, but not just the availability of benefits. It's ensuring that everyone who is eligible for those benefits can actually receive those benefits. And as we know, there are a number of factors that can keep many who are eligible in our communities from receiving those benefits, such as language barriers, for example, or certainly in working class families, having heavy work, paper, or administrative barriers would certainly keep many from accessing their benefits. So what does the healthcare reform legislation do? First, with regard to Medicaid, before this legislation, it wasn't enough that you met the income guidelines. You had to meet a number of other factors, for example, having children or having a disability. There are sort of other compounded factors to receiving Medicaid. This legislation says even if you are an adult without children, you can now be eligible for Medicaid if you receive, if you meet the new income guidelines. The new income guidelines say that those those in households up to 133% of the federal poverty level are now eligible. So what does that mean? In 2010, just to give you a reference point, 133% of the federal poverty level means a gross annual income of $14,403.90 for an individual, $24,352.30 for a family of 3, and $29,326.50 for a family of 4. As we know, though, the federal poverty level the definition of the federal poverty level can change from year to year. So this is just for 2010 as a reference point, but it's something that we'll have to keep on checking in on. In addition, in terms of improving access, we know that right now one of the major problems with the health industry is that they exclude people based on a number of pre-existing conditions. This healthcare reform legislation is going to end that practice. Starting in 2010, many states will hopefully be starting high-risk pools for individuals with pre-existing conditions. Many states already have high-risk pools. In addition, as Anne spoke to earlier, dependent coverage will extend up to age 26, and also employer-based insurance is going to be more significant force or more prevalent as employers of 50 or more full-time or full-time equivalent employees must provide employees with coverage or face monetary penalties. So just to emphasize, that's employers of 50 or more. So there is a small business exemption there. And finally, one of the great innovations is a streamlined application process. So when individuals, low to moderate income individuals, apply for benefits, they just have to fill out one form for checking their eligibility for Medicaid, the Children's Health Insurance Program, and also on the health insurance exchanges, which I'll explain on the next slide, actually. So that wraps up access. In terms of improving affordability, again, what does affordability mean? It's many people who are employed still cannot afford insurance. So when we talk about affordability of health insurance, we mean that purchasing health insurance is not going to create a financial hardship. One of the major innovations, and I think that everyone has probably heard about the exchanges on the media, it's been spoken of. What exactly are the exchanges? So the exchanges, we refer to it, I guess, as a one-stop shop. It's a marketplace, and it will be accessible to everyone online. It's essentially a marketplace full of private health insurance plans that are going to be more affordable than what's out there now. And it'll be this marketplace will be targeted to individuals and to small businesses. And again, as we know right now, as an individual, independent, trying to buy independent health insurance, it's quite expensive. Many people can't afford the premiums, and many small businesses cannot afford to purchase insurance for their employees either. And so through the exchanges, these more affordable private plans will be available. So we're excited about that. And in addition, for those who are living at up to 400% of the federal poverty level, that they will be receiving tax credits for purchasing plans through the exchanges. 400%, just again as a reference point, 400% of the federal poverty level means a gross annual income of $43,320 for an individual in 2010, and $88,200 for a family of 4. And again, these values can change as years go on. Also, I want to emphasize that For the territories, they have the option to establish an exchange, and they will receive funding to provide subsidies for their citizens. The federal matching percentage for territories' Medicaid expenditures will also increase from 50% to 55%, and an increase in the territory's Medicaid funding caps by 30%. As we all know, though, while this is certainly a step forward, it does not bring the territories to parity with what the states have. So, while we're pleased with having these advancements, we certainly want to see more in that area. And finally, small businesses, which here is defined as 25 full-time equivalent employees or fewer, will receive tax credits to provide health coverage for their employees. And sorry, one more slide to go on affordability. I want to take time to address the senior population. There is a Medicare donut hole that's referred to those who have to pay full cost for their health insurance, for their prescription drugs because they are in the donut hole. They will get a $250 rebate in 2010 and increasing subsidies until 2020 when that donut hole is closed. Finally, a ban on lifetime limits and annual limits applied to individual and group health plans. And the individual mandate, which many people have spoken about, it's essentially saying that with very few exceptions, everyone will be required to provide health coverage, the principle being that the more people that pay into the system, the cheaper it is for everyone. So just to note, though, that this does not apply to the bona fide residents of the U.S. territories. And I will hand it back to Deanna.
Okay. Thanks, Alice. And a number of you have asked for copies of these slides. Just to let you know that after the webinar is over, we will be posting the presentations on the Health Forum website, which will give you the link for that at the end of this webinar. So we'll move on to our next presenter. Rita Pinatas is the Director of Minority Health Initiatives at Families USA, a national nonprofit working to attain high-quality, affordable health care for all Americans. Rita brings with her an expertise in the analysis of racial and ethnic minorities' access to quality, affordable health care and in providing the necessary resources within communities of color to advance health. Rita has worked previously on the mitigation of health disparities at Grantmakers in Health and at the Washington Business Group on Health. She's also built her expertise in health policy at the Centers for Medicare and Medicaid Services and the Women and Children's Health Policy Center at Johns Hopkins School of Public Health. Rita holds a master's degree in health policy and management from the Johns Hopkins Bloomberg School of Public Health. So I'll turn it over to Rita now.
Thanks, Deanna. And I just wanted to thank Alice as well for putting together this important call and inviting me to speak. I just wanted to start off by saying how excited we are to be talking about healthcare reform implementation. It's a long road to get here with a lot of hard work from many of you in your communities. But now the real work begins in earnest to make sure what we just got passed works for all communities. Next slide, please. So Alice asked me to focus on the pieces of the new law that will mitigate disparities. So I wanted to focus on 6 key areas: data collection, the Federal Office of Minority Health, community health centers, prevention and public health, language access and cultural competence, and workforce diversity. And as Deanna said, 2,400 pages of new law, the devil really is in the details. And so I wanted to highlight, just provide some of the highlights of some of these 6 components. Next slide, please. So we all know that in order to fully monitor and address disparities in a systematic way, we need to first make sure that the data is there and that it's collected in a way that makes sense for policymakers, for advocates, for communities to use. But data collection today is currently really fragmented, and it's not readily available to folks that need it. So the new law puts a few processes in place that make sure that this will happen in a more coordinated and systematic way. It does this by requiring, within 2 years of enactment, so in 2012, that any federally conducted or supported healthcare or public health program, activity, or survey will collect and report data on race, ethnicity, gender, primary language, and disability status. It also mentions collecting data by subgroup and oversampling for smaller populations, which we know is key when talking about populations, especially Asian Americans, Native Hawaiians, and Pacific Islanders. And it also requires the Secretary of HHS to analyze data and monitor trends in health disparities and report that to each of the federal agency heads. So CDC, HRSA, the Health Services and Resources Administration, agencies that have a role in providing health and health care and reducing health disparities federally will get this data. Next slide. Also in line with streamlining and strengthening some of the federal government's role in addressing disparities, Anne mentioned this, but I'll provide a little bit more detail. It codifies into law the Federal Office of Minority Health, and it places it under direct reporting responsibility to the Secretary of HHS. It also codifies into law several of the key federal agencies which might have existing offices of minority health, but this makes them permanent. So with changes in administration or budgetary challenges, these offices can't be eradicated. It's codified into law. Next slide. The healthcare reform law also increases funding for community health centers, which we know plays a disproportionate role in communities of color and which we know will continue to be a safety net for many members, particularly of our community. It does this by authorizing and appropriating $11 billion in new funding over 5 years. So $9.5 billion of that funding will go to expand current capacity at current community health centers. And it's estimated that it'll increase capacity to serve 20 million new patients and enhance services for those patients. And then $1.5 billion will go towards expanding and improving existing facilities at existing sites and constructing new sites. And then it also establishes a demonstration program for health centers to receive funding to help high-risk individuals draft patient wellness plans. Next slide, please. So a provision in the bill that hasn't been discussed as readily as some of the things that you might have been hearing about in the media, the exchanges, the Medicaid expansions, the tax credit for small businesses, are the provisions related to prevention and public health that lay the foundation for a coordinated federal response to really address upstream factors related to health. And in some ways can be a game changer for the healthcare system and in how healthcare is delivered and organized in this country. So there is significant investment in community-based prevention and public health. And it does this through the creation of a couple of different entities. Most importantly is through a prevention and public health fund with funding of $15 billion over 10 years. Funding appropriations begin in fiscal year 2010 and increase thereafter. It's appropriated at $500 million for fiscal year 2010, and then it increases thereafter. Part of this funding establishes what's called community transformation grants, and these grants will promote community-based prevention initiatives aimed at addressing chronic disease and reducing disparities. The legislation specifies that grants will be awarded to state and local government agencies as well as community-based organizations. It'll be run out of the Federal Centers for Disease Control, and it appropriates such sums as necessary through fiscal years 2010 and 2014. And timing is unclear in terms of the funding for this year. It also creates a council made up of heads of the federal departments and agencies, including HHS, but also the heads of agriculture, transportation, labor, dedicated to promoting healthy policies at the federal level. And, when you think about it, this makes sense. When you talk about health and health care, oftentimes we just think about the healthcare system. But having the heads of agencies from agriculture and transportation can really help to look at some of how some of the policies that they're looking at could eventually impact health, which people might not readily think about, but, where you build a subway system or how you improve a subway system has an impact on health and healthy communities. It also creates an advisory group composed of 25 stakeholders that will advise this council on the development of program and policy recommendations. Next slide. So in the area of language access and cultural competence, which many of our communities are heavily invested and interested in, there is language in there that requires plans in the exchange that Alice talked about to develop benefit and coverage documents that are culturally and linguistically appropriate. Unfortunately, it doesn't include a requirement that once someone is actually in the plan, that health care is provided to them in a culturally and linguistically appropriate way. It does not specify that. It does provide grants for training healthcare providers on culturally appropriate healthcare services. I think this is an area where it's important to note that we tried for stronger language about providing interpretation services or other language services as a basic element of patient care, and this is definitely an area we'll continue to push on, both in terms of a legislative strategy, both national and state, as well as in how regulations and rules are written and set up, particularly related to the exchanges and Medicaid expansions. Next slide. So lastly, just on these 6 provisions and elements, we know that while people of color make up more than a third of the U.S. population, this diversity is not reflected in our current healthcare workforce. And while some groups of Asian Americans may be overrepresented in the healthcare workforce, there are numerous subpopulations of Asian Americans, Native Hawaiians, and Pacific Islanders especially that are vastly underrepresented. So healthcare reform attempts to move us a bit closer to diversifying the healthcare workforce. It does this by creating a permanent advisory committee that, among other responsibilities, monitors the diversity of the workforce that we currently have and constantly provides recommendations on how to improve it. Again, it's a way to systematically monitor the state of workforce diversity in this country and report on it. And then increases funding and scholarships for disadvantaged students, particularly giving consideration to schools with a track record of training diverse populations. Next slide. So last, I just wanted to end with what all this means for state and local advocates and all of you on the call. As I mentioned in the beginning, while passage of the healthcare reform law was a culmination of decades of hard work, now is where the real work begins to make sure that this is actually working for communities. We saw, particularly at the end of this debate, that there was a lot of misinformation out there about how this law will impact people in communities. So there is a need to get the word out there about what's really in this new law. This webinar and others that the Health Forum will sponsor as part of this will help to facilitate this. But we really do need folks in their communities talking to their neighbors and family about what's really in the bill. There are a few key provisions, as we've talked about, that will take place right away. For example, the having young adults be eligible for their parents' plan up to age 26. That folks need to know about right away, many of the ones that Alice talked about. And then when the coverage expansions come into effect, really making sure people know what they're eligible for and then how to enroll. Another key opportunity for advocates will be to provide comment on some of the regulations and guidance that will be coming out, which will help determine how some of these provisions are actually implemented. So look to folks like the Health Forum and Families USA to keep you abreast of opportunities to weigh in with the administration. And then lastly, I can't emphasize enough the power of stories in making change. We saw this with the healthcare reform debate, but now as the law is being implemented, we need more stories from folks, both those that demonstrate how the new law is working for people in communities and who's benefiting from it, like small businesses or people that are eligible to stay on their parents' plan after graduating from college, that might be between jobs, as well as how the law might fall short, particularly for some of the areas I know Sona will be addressing and where we still need to be active. So I'll end there to make sure we can have some time for questions and discussions and turn it over. Back to Deanna.
Thanks, Rhea. Okay, moving on. We will now hear from Sonal Ambagalkar, who will talk about how immigrants will fare in healthcare reform. And Sonal is the health policy attorney in Los Angeles for the National Immigration Law Center, which is a national nonprofit recognized for its expertise in advancing the rights of low-income immigrants. Sonal's work focuses on improving low-income immigrants' access to health care through policymaking at the federal, state, and local levels. Sonal has also previously served as a supervising attorney at the Health Consumer Center of Los Angeles, where she oversaw a multi-language hotline that provided callers with help on a variety of health-related issues. Sonal earned her JD degree from the University of California at Davis. Sonal, are you still there?
Can you guys hear me now?
Yeah, now we can hear you. We could not hear you for there was some dead air
Okay,
for a while and got my heart
technical
stopped.
difficulties. Okay, thanks Deanna and thanks Alice for the invitation, and I'm sorry for the delay. So in the interest of keeping us on time, I'm going to jump through and focus on sort of the Immigrant Act aspects of the healthcare bill, and I'm going to try to go beyond what the media has definitely been covering. So next slide, please. I'm not going to cover all these bullet points, but I wanted to take a bird's eye view of sort of what's good in the healthcare bill. And this is in general, not necessarily for specifically for immigrants, but in general for the Asian Pacific American community and Pacific Islander community at large and communities of color. So I wanted to flag again, this does allow the bill, despite its deficiencies, does allow more lawfully present immigrants access to affordable health care, and we'll talk about where exactly that is. And then we do have more investment in community health centers, which predominantly serves communities of color. So those are two important aspects of the bill, and I think the others Rhea has very well described. And the last point on this slide is just to remember that there's more federal money that should be coming into the states because of this bill, and given the state budget cuts that many of you are facing, I think this is something we need to highlight about the bill. Next slide. What's bad about the healthcare bill? There's a lot of us have our specific issues that we wanted to get passed in healthcare reform that may not have made it in. But I think what was hard for many immigrants is to see immigrants completely being excluded. So the very well-known exclusion and the Joe Wilson comment about immigrants being covered made the White House jump to and Congress jumped to actually excluding undocumented immigrants from buying health care insurance, and we'll talk about that in detail. The second bullet about the fact that you have to exclude people requires all of us, even if we're a citizen, to provide proof of a citizenship and immigration status in the exchange. And this is, again, even if you're not applying for tax credits, if you're paying full cost, in order to exclude people, you have to verify everybody. And so this is going to add additional paperwork and possibly bureaucracy for all of us. So that's an unfortunate part of the healthcare bill. And then the third thing I want to flag is just that the bill unfortunately continues discriminatory barriers that we've had in the federal law for many years against lawful immigrants who are barred from Medicaid, and then also the residents of compact-free association states. We were hopeful that that would also be corrected, and I know the Health Forum is working on that still. So next slide. I'm going to present sort of the sort of big categories of immigrants and sort of where their coverage is and isn't after the health care reform bill passed. And I'll be happy to take questions for specific groups that I may not have covered, but these are just buckets. And again, a lot of the details are still to be determined. So we're going to cover naturalized citizens, legal immigrants, and the children of undocumented parents. So naturalized and undocumented immigrants themselves. So the first group is naturalized citizens, and again, just in our country, naturalized citizens and U.S.-born citizens should have the same rights. We know sometimes there's challenges, so just want to make it clear that there's no distinction between naturalized and U.S.-born citizens in the health care bill. Citizens are citizens, and so naturalized citizens should be eligible for all the same provisions that U.S.-born citizens are. And as I mentioned, the verification piece will be applied to everybody, and so verification of citizenship status when we buy health care insurance in the exchange is going to happen. For naturalized citizens, because you're a citizen, you can be verified by the Social Security Administration's records using your Social Security number. For the most part, that's an easy verification, but we do know that in general there are higher error rates and mismatches of data for naturalized citizens, so that could be a problem when you try to get verified, when your citizenship gets verified electronically. So if they're unable to verify you through the Social Security database, they can go through to the immigration database, which is housed in the Department of Homeland Security, and they can verify your citizenship that way. If that still doesn't work, everyone's going to have an opportunity to provide proof or other records to verify their citizenship. Naturalized citizens are subject to the individual mandate, and they can apply for all the other exemptions that everyone else can, and they will be subject to the tax penalty if they do not have insurance. And then as of right now, there's no specific changes for that will affect employer-based coverage, that if you're currently covered by your employer, your immigration status or citizenship status is not a factor. Next slide. Legal immigrants, and I'm going to use the term legal broadly. There's several categories in this group, but the current healthcare law says that immigrants who are lawfully present is the term that's used in the healthcare law. Immigrants who are lawfully present in the U.S. can buy healthcare insurance in the exchange. They will have to be go through verification, but there's no exclusion. They can apply for tax credits that will help reduce the premiums and reduce the cost sharing or co-payments. And they are eligible for the high-risk pools that are being created in the states right now. Only certain categories of legal immigrants are going to be eligible for federal Medicaid, and this again is a remnant of welfare reform that happened in 1996. Even though you're lawfully here, there's only a very narrow category of immigrants that are federally eligible for Medicaid. And then they're subject to a 5-year waiting period and other barriers. We were hopeful that the healthcare law would fix that problem, but it kept that barrier in there, unfortunately. However, this does not prevent, the law does not prevent states from covering a broader group of legal immigrants. So if your state is already covering more than the federal guidelines allow, they can continue to do so with state funds. And we encourage states to do that as more of their uninsured population does get insurance, that we hope that states will cover those that are still ineligible. But again, the same group of low-income immigrants can buy health care in the exchange and receive subsidies. So I think that was the intent of Congress, was to at least give them that option. And as a result, then, because they are allowed to buy through the exchange, they are subject to the mandate and will be subject to tax penalties, but again can claim that they, the access is unaffordable and then therefore exempt from the mandate. And again, there's no specific changes right now based on if you're a legal immigrant covered by your employer. There's currently no changes expected in the healthcare law on that based on your status. Next slide. Sorry, next slide. Oh, thanks. Okay, so undocumented immigrants is, I think everybody is very familiar with a lot of these restrictions. Basically, if you're undocumented, you're not able to buy in a health insurance exchange at full cost. You're not eligible for the tax credits. However, there is an exception if you have family members, specifically undocumented parents who have citizen children, for example. citizen children can apply for their own tax credit and for their own insurance through their own application. How that's all going to be worked out is still to be determined, but that is, the whole family is not excluded. It's just certain members. Undocumented immigrants remain ineligible for federal Medicaid, the CHIP program in your state, and Medicare. The exceptions are that we still have emergency Medicaid available for undocumented immigrants, and hopefully, given the Medicaid expansion, that will cover more undocumented immigrants. And then the other exception is, as the law is today, if you have eligible family members, even if your other family members are undocumented, you can apply for Medicaid, CHIP, or Medicare. So again, the typical example is citizen children of undocumented parents should be able to apply for Medicaid and CHIP even though their parents are undocumented. And then because they're not eligible for the exchange, they are specifically exempt from the individual mandate in the law. It's still unclear how that actual exemption will apply and how an immigrant can safely claim they're undocumented, and that's why they are not subject to the mandate. Next slide. So because of the lack of really more coverage for them, I just wanted to flag for everybody that what do undocumented immigrants remain eligible for? They do remain eligible for all the other health programs that are available regardless of status. So any public health programs in your state and community health care services that are available regardless of status, so they should be eligible. And because EMTALA has not changed the requirement that hospitals provide emergency care regardless of insurance or immigration status, undocumented immigrants should be able to seek emergency care without problems. Community health centers can continue to provide non-emergency health care, and if you have an undocumented child covered currently by group insurance, there should be no change to that group insurance right now. So what happens to all these undocumented immigrants after the exchange gets created? There's been talk about maybe there's going to be insurance outside the exchange that's offered and available for undocumented. That's possible, but because it's outside the exchange, we're not sure how affordable or comprehensive those plans will be because they're not required to meet all the other guidelines for plans that are offered in the exchange. Next slide. So I've run out of time, so I will cover just the undocumented children. Basically, I think we covered many of this. You know, undocumented children also have the same restrictions as undocumented adults. And just to remember that they are eligible for programs that are available regardless of status, the third bullet. And the next slide, please. And again, I mentioned many of these factors about children of undocumented parents. If they're U.S. citizen or legal immigrant children, they should be able to apply for the programs that they're eligible for, either on their own or despite the fact that their parents are undocumented. And as a result, they're likely to be subject to the mandate as well, so they will need to get enrolled in the right Medicaid, CHIP, or health insurance plan. Next slide. These are things I just wanted to flag for folks in terms of advocacy steps. In terms of improving immigrant workers and immigrant families' access to coverage, the small business tax credit may be an opportunity. And other things to work on, as Rhea had said, is we will definitely be following up with you guys in terms of opportunities to weigh in, but there's going to be issues about how families get enrolled, how employer coverage is kept the same as it is today, and we don't want additional verification happening for health insurance at the employer level, and that we really need to find good outreach and enrollment mechanisms for immigrant populations. Next slide. Again, all these things I think you can read, basically ensuring every opportunity for expansions that we have the state include immigrants, and then to watch out for any restrictions or reductions in access to the certain populations. Next slide. And I just wanted to flag here, I won't go through all these points, but everybody has talked about how immigration reform is going to fix things for healthcare, for immigrants in healthcare, and I just want to flag that we're still uncertain about the timing of immigration reform, but that is not the vehicle that we expect some of these restrictions to be addressed. In fact, we expect further restrictions to be thrown out in the bill, and we'll have to all defeat those restrictions. So just look for other opportunities and know that it's not likely to happen in an immigration reform bill, but that legal status will at least help people increase their wages and other work opportunities. And with that, I'll close. Thank you.
Thank you, Sonal. And if people don't mind, we're getting close to the hour. If we could go a little bit over time, we can get to some of these questions. And sorry, if many of you asked for more information about where the data came from the slides, or wanted additional data, I would ask you if you could just email Alice with those requests, and we'll try to get back to you. I don't want to take up time on the webinar because I don't think people know it off the top of the response off the top of their head. And plus, we want to make sure we get the information that you need in an accurate way. So I'm going to go ahead and there's questions here, I think, for all the panelists. And maybe I'll start with Alice. If you could, let's see, talk about how does the employer-based threshold of 50 for the employer mandate impact Asian Americans and Pacific Islanders, especially since there's a disproportionate number of Asian American and Pacific Islander businesses that are under 50 employees.
Sure. Well, for our small businesses, because there's that exception, it means that the mandate for employers to provide insurance will not apply to them, which means that if those small businesses do not provide their employees with insurance, they will not face those severe monetary penalties. So for our small businesses, that definitely is a protection. At the same time, I would certainly encourage small businesses that are 50 or under to look at the small business credits that are available to small businesses with up to 25 full-time employees or full-time equivalent employees that would certainly help them provide affordable health insurance for their employees.
Okay, thank you, Alice. I just want to note on that the Internal Revenue Service just sent out postcards to small businesses to let them know about the credit, but those postcards are only in English. And so another person on the call asked a question about whether there would be translated information on some of these topics, simple translated information on these topics. So we are going to be working on that issue and hopefully have those resources up on our website. And actually this person also volunteered to help with some translation in Ilocano, so we appreciate that. So if you would let us know, we'll figure out how to coordinate some of that, as well as continue with our advocacy, because under Executive Order 13166, the federal agency should be translating this information into commonly spoken languages. So we will continue with that advocacy, as well as try to make that translated information as available as possible. Another question for you, Alice. Someone wants to know a little bit more about the donut hole. What does that mean in the Medicare program?
Okay, well, this is good.
if you don't feel, I would have to say that I don't think any of the people on the, well, I don't know, unless Sonal or Rio want to jump in. I don't think anyone on the call is a Medicare expert, so we might maybe...
I can actually take that.
Okay.
So for Medicare beneficiaries and Part D of Medicare, so if you don't know what that means, then you're probably not in Part D of Medicare. But essentially Part D covers prescription drug costs. And so once a beneficiary's drug costs reach $2,700, Medicare will no longer provide any assistance for the cost of those medications. So once you've accrued $2,700 of prescription drug costs, Medicare is going to stop providing any financial assistance until your medical costs get up to $6,154. So that essentially is the donut hole. And only once you reach $6,154 will Medicare start back. So you see that there's a gap there. And so once, so in 2010, first they're going to provide a $250 rebate, and then, which certainly we know is not enough to help individuals in this gap, but it's a start. And progressively into 2020, there will be more federal subsidies, and also I believe the health insurance companies will be providing a 50% discount for Medicare Part D beneficiaries for their brand name drugs.
Okay, thank you, Alice. The next question I'm going to ask Rita. Rita, could you talk about how the data collection provisions within the healthcare legislation, how does that connect with the OMB standards?
Sure. So what it does is in the legislation, it says that at minimum OMB categories should be used when collecting race, ethnicity, language. But it also talks about collecting subgroup population information where feasible and where possible. So it goes a little bit further in specifying that subgroup population categories should be collected when possible.
Okay, and I think the person also wants to know because the standards, the current standards, aren't really being enforced. Is there an enforcement mechanism in the bill for this new requirement?
You know, the language is not clear on kind of what enforcement mechanisms will be put into place. I imagine that will become clear as they're writing regulations or rules on how this is implemented. So again, I think this is a way for advocates and community members to weigh in when you know, the federal government is asking for public comments on how some of these regs will be implemented.
Okay, thank you. And now I'll move on to some questions for Sonal. So the person just wants to clarify, although I think you made this pretty clear, but I'll let you say it again. Low-income legal immigrants who have been in the United States for less than 5 years will be penalized for not having health insurance even though they can't get Medicaid. I think this person wanted to hear it from you.
Clarify that, yeah. So yes, all lawfully present immigrants are subject to the mandate. They are eligible to buy in exchange, but because of the current Medicaid rules, Medicaid is not an available, affordable option for them, so they're going to have to buy insurance, private insurance in the exchange, and that to meet their requirement, their individual mandate requirement. It's unfortunate, it makes no sense, but we're hopeful that states will realize how difficult it is to implement and push Congress to fix it.
Okay. And then, well, okay, the second question was about mixed status families. And what about the qualified children of undocumented immigrants? How can we ensure that they, I'm just going to rephrase this question, how do we ensure that they still can get coverage?
So any child who's eligible for health care programs such as Medicaid or CHIP, they're currently already eligible. The challenge, of course, is parents are always often asked inappropriate questions about their status or their income. So that more can be done to educate the state and state eligibility workers that the relevant questions are about the child status. The social security number of the child is the only one that's needed, not the parents, and that proof of income can be something like a letter from the employer or even a self-declaration of income. Often those are the barriers that undocumented parents face in trying to provide proof of income. So they should be allowed to provide other proof. We have on our website, at the NILC website, a helpful immigrant-friendly outreach and enrollment. I'd be happy to send that to Alice. And they have some tips about how to make applications and enrollment procedures better for immigrants and mixed status families. It's an ongoing issue, and we would love your feedback and help on that at the state level.
Just a follow-up, Sonal. But what about the families who will be afraid to even apply?
That is a concern. I think, you know, the one thing about having a blanket exclusion on people does create a chilling effect on people and misinformation. So just because parents are excluded, they will be less likely to want to apply for their children. And so I think part of the outreach and education that has to happen at the local level has to be targeted towards immigrant families and really helping them understand that applying for their child will not create immigration consequences for them, and that there are other opportunities for them also to seek care, even though they're completely excluded from the exchange, that they should be able to seek health care services at the community clinic and not delay or forgo care.
Okay, and I'm sorry, Sonal, there's a follow-up question to your last response about legal immigrants in the U.S. for less than 5 years who are not eligible for Medicaid. The person wants to know, aren't they exempt from the penalties for being uninsured if they're too poor to pay taxes?
That's true. So there is an exemption. There's multiple exemptions. If you're low income, if you don't file taxes or have tax liability for religious reasons or other reasons, and if it's just unaffordable. So even though as a lawful immigrant I tried to buy insurance in the exchange and try to apply for a tax credit, if it's still unaffordable to me, I can claim an exemption. I can also just say I'm too low income. There's not a blanket exemption for low-income legal immigrants. They are subject to the mandate, but they can apply and say that they're too a low income or that health care is unaffordable.
Okay. Thank you, Sonal. And thank you, everyone, for your patience and staying a little bit over time. I know there are some other questions that I'm sorry we didn't get to, but please feel free to email those to Alice, and she'll either direct them to one of the panelists or we'll respond to them in some other way. So I just want to thank everyone for their participation, especially our panelists, Sonal and Rita and Alice, for the great job in pulling this together. We have Alice's email on here, and then the, let's see, we also have, we'd like your feedback on this webinar. So the next slide has a link to a SurveyMonkey where we have a short survey where we'd like to find out for you how the webinar experience went and how the presentations were and your ideas in particular for future topics for webinars. And then finally we have some resources for you. So this concludes the webinar. I want to thank everyone. Maybe we can leave this slide up here for a while, but as I said, all these slides will be, all the presentations will be posted on the Health Forum webpage. And I also encourage all of you to sign up for the Health Information Network so you can get future emails from us with new resources and action alerts. So thank you so much, and this concludes our webinar.